We're going to go ahead and get this meeting started. Welcome, everybody. I'm going to give everybody just a few more seconds to make sure that they're getting in and they can see us. Perfect. And everything, it looks like this webinar is being recorded. There we go. Perfect. Well, good afternoon, everybody. Welcome to today's Grand Rounds. I'm Christy Capra. I'm your PediNet coordinator, and I am here to weather the storm with you today. How's everybody doing out there with this bit of snow and cold that we've got going on? Hopefully everybody's staying warm and safe. So before we begin, I want to remind you how to claim your CMEs. And remember, there's only 30 days to claim this. Of course, reach out to us if you have any questions or need further help. And at the end of the lecture, there will be time for questions. So please feel free to type your questions in the chat, or raise your hand at the end of the lecture and I can unmute you as well. And now we have our amazing Jill Shipley. She's our Pediatric Trauma Program Manager for Randall Children's Hospital to give our formal introductions today. Thank you for being here, Jill.
Thank you. Hi, everyone. I'm so glad you could join us for this wonderful talk today. It is my extreme pleasure to introduce Lisa Nichols. She is the Trauma Program Manager at Wolfson Children's in Florida. They are a level 1 pediatric verified trauma center, both with the American College of Surgeons and with the state of Florida. Lisa has been involved in pediatric nursing care for over 35 years, covering pediatric intensive care unit, pediatric emergency department, and the past 17 years of her career in pediatric trauma program management at 3 different centers. She is also an American College of Surgeons nurse reviewer for the Verification Review Committee. She's actively involved in the Pediatric Trauma Society, having served as a board member for many years and also as one of our past presidents. She currently serves on 3 of their committees to promote nursing leadership, process improvement, and program planning. She's a member of the Society of Trauma Nurses and serves on the Pediatric Trauma Across the Care Continuum Committee. One of her passions is drowning prevention. She's actively involved as an executive board member of the Joshua Collingsworth Memorial Foundation, a drowning prevention nonprofit foundation. Take it away, Lisa.
Great. Thank you so much, Jill. So in all of that, and I'm only 30, so those of you who believe it, it's really kind of crazy how you can do all those things in the womb. We'll kind of make that go on. So as unfortunately, I've been telling these guys, I sound a little like Snuffleupagus. I'm getting over a cold, and I know you'll feel sorry for me because I have, a summer cold because it's 84 degrees here in Florida today. So, but I will, hopefully my voice will hold out for this entire thing and we'll take it from there. So, but hopefully everybody can hear me okay and we'll go on. So CME disclosures, no one pays me for any of this besides my regular job. If anyone would like to, then we can talk offline. Let me know how that goes. So the objectives today, I wanted to talk about this dichotomy of drowning is really what I've titled this talk. So you'll see that the objectives that I have listed here are really illustrating the dichotomy of the non-trauma drowning patients and injury prevention with drowning programs. And then discussing differences in different trauma programs, defining really what is a pediatric trauma patient. So it's an area of discussion that happens a lot in our world of pediatrics. And so I wanted to really kind of touch base on those things. And as Jill alluded to, I am part of the Joshua Collingsworth Memorial Foundation as an executive board member. So this is really a lot about me, and it kind of tells you a little bit more about me by some of these pictures. But how I became really involved in drowning and drowning prevention has to do with really starting out my nursing career. So when I started my nursing career back in the dark ages, I started in Chicago, and my very first patient that I ever took care of in the pediatric intensive care unit was a drowning patient. And it, unfortunately, was a drowning patient who passed away. And it was a horrific experience. I won't go into the details, but it was a really experience that I will never forget. So, and unfortunately then bookending my career at the bedside was again in the pediatric intensive care unit in Omaha, Nebraska, where Joshua Collingsworth was actually taken care of in our ICU, and again, unfortunately passed away. So that was kind of a weird bookend to my career at the bedside. So it really kind of drove me to want to do more for drowning prevention. So being involved in this foundation has been fantastic. I love the message. I love the information and stuff that they have. But really what has driven me toward trying to do more with this from a trauma manager perspective is getting better data. So we have, lots and lots of information that people can tell you about drowning and all of these great things and stuff that we should be doing, to prevent drowning. But are they really helping, and how do we know that? So when you look at some of these pictures, so this, down here in the corner, that's actually me, in the old famous bathtub picture. So I started loving water at a young age. And at the age of about 18, 19 months, my mother, who didn't know how to swim, was taking swimming lessons at the local YMCA, and they had me kind of in the child section that I was supposed to be watched. Well, being a child and apparently being as wily as I am as an adult, I managed to sneak away and got into the pool and fell into the pool. And so they found me at the bottom of the pool, weirdly holding my breath. And my mom determined at that point that I would be a swimmer because I really wasn't injured from it. But it scared my mom enough into the fact that she then stopped doing her swimming lessons, which made no sense to me. But then, you kind of move forward, and the picture up here with like my nephew is teaching my nephew and nieces how to swim from an early age. I was a, water safety instructor. I was on the swim team. I was very involved in swimming throughout my entire career. And so it really was something that I was passionate about, making sure that all of the kids that I knew also had some sort of, drowning education, drowning prevention, and learned how to swim and kind of knew what to do with that. So this is really the impetus that kind of led me down this path and really wanting to do what I could from a drowning prevention standpoint. As Jill said, so I got into this about 17 years ago, and my first job was I was at the bedside in the PICU, and after almost 20 years in the PICU, I was like, I'm going to need a change. And my chief nursing officer at the time said, we want to be a trauma center. So is this something you'd be interested in? And so I'm like, well, of course. And, I took the job and didn't know much about it. And I was handed at that point a yellow book. You don't even know what the yellow book is, but the yellow book, that's kind of like a trauma Bible. And so I took that information and started developing a trauma program. And the reason I give you all that information is to say, I was the trauma registrar, I was, the PI coordinator, I was injury prevention, and I was also the manager and stuff of the program when I first started. And so, being the only person I had to answer to, I decided drownings were incredibly important, and I put them in our trauma registry. We skipped forward, and I then got an injury prevention coordinator and started developing more relationships, joined the Joshua Collingsworth, executive board, working with them to work on drowning prevention, worked with the Parks and Rec department for this, the city of Omaha, and we were able to do like Josh the Otter. So what Joshua Collingsworth Foundation did with their program, so let me take a step back, did with their program is they actually developed a character called, Josh the Otter. And Josh the Otter is basically a story that tells kids to not go near water unless an adult is present. And that really was the message that they wanted to put forth. So we took that message, we took it out to Omaha Parks and Rec, to all the swimming pools and stuff in the city. They were doing readings at safety checks. They were doing float for life, lessons and stuff at safety checks. And with the relationship, I was able to get data from the Omaha Parks and Rec team, who were then able to tell me, here's how many near drownings we had. Here's how many actual drownings we had of patients, that we were actually seeing. And I'm like, well, this is great. I'm like, good data. We'll take this. We'll move it forward. I actually had an injury prevention program that we were able to see a 38% decrease in near misses that first year that we started doing these safety checks. And I was like, well, this is easy. I don't know what people talk about with injury prevention, that you don't see changes. I'm like, we've been able to make great changes with this. And so moving forward, I was like, well, I'm just going to take this with me. Well, then come to find out it's not the same everywhere else. And when you get other people involved, they're like, well, drowning is really not trauma. And so we don't really keep trauma data. And so how do you really take it from there? And that's really where I kind of was like, I had to take a different look at this and figure out where I could really move forward. So one of the aspects that we started working on through the Pediatric Trauma Society guidelines was looking at different work groups. So these are different guidelines and stuff that are either in the works, have recently been developed, or we're still working on. And so I was, I saw pediatric hangings and drownings. I'm like, I'm in. This is all about me. So let's see what we can do to set up a guideline on drownings. We went back and forth for over a year of looking at this different guideline. And let me just tell you, it is one of those things that's kind of now on a back burner because nobody can really decide, is this a trauma? Is it not a trauma? How do we make it go forward? How do we get a guideline? Should we activate? Is it something that we should be doing? So it really is still one of those things that we really went round and round, meeting monthly for a year, that we really couldn't even come up with a basis or a basic way to start a guideline from a trauma perspective. So we did more research, and one of the papers that we found that we brought forward was one that, what is a trauma patient? So, and the NTDB, so those who are involved in trauma care, the NTDB has a lengthy definition that gives you an algorithm that if it's this, then it's this, then it's this, then it's this, then it's a trauma patient. And it didn't fall into that category for being a trauma patient. But one of the people I was working with found this article that was talking about that trauma is not a surgical disease, because they always tell you trauma, if you can fix it with surgery, then it's considered a trauma. And it's like, well, but that doesn't necessarily mean all traumas are surgical, which that's true. Not all of our patients go to surgery. So it's really not a surgical disease. So, and in this, when they were talking about this, so this is actually out of Ontario, Canada, they were talking about, we don't define other disease processes by modes of therapy. Is acute psychosis a neuroleptic disease, or, is low back pain a physiotherapeutic disease? Is a volvulus an endoscopic disease? Well, of course not. So trauma must be multidisciplinary and comprehensive. And so it's not the solely surgical management of injured patients. That's not what's going to lead to measurable gains. It's really everyone working together through the initial phases. That trauma is not always surgical, both pre-hospital care, the ED care, and critical care. How do they fit into this? So trauma in and of itself is not necessarily just a surgical disease. So how do we make sure that they're included? So I was encouraged. Maybe we can go forward. Then the next person presented this article that it says trauma remains a surgical disease. And I'm like, okay, all right. So this one goes into and talks about from Dr. Bensard was the leading author of this article in the Journal of Trauma. And they hypothesized that surgical intervention and judgments are often still required in injured children and adults, and that almost 55% of children admitted for traumatic injuries require operative interventions, which of course 70% of those are orthopedic patients. So 10% only being neurosurgical, and only another 17% of those being general surgery patients. So their conclusions led to that there's a continued need for surgeons to stay involved in the care of trauma patients, particularly the most critically ill, because they might need surgery. Well, I don't know about you guys, but I know for me and working with surgeons, they don't really want to talk about drowning patients unless they've got an injury somewhere that they might be able to fix. So this is kind of where our discussion went as far as how do we really move this forward? How do we really try to make a difference with this? And how do we really try to write a guideline that's going to make any sense? So back on these are the questions that we put forth, and with the upcoming Pediatric Trauma Society meeting that we had last year. So in looking at all of the submissions and stuff that were done for it, there was actually one that was actually on drownings, but we also had other submissions and stuff on suffocations and safe sleep. So then it adds into those conversations also. Are those patients, should they be considered trauma patients, and why aren't they? So, and how do we really make sure that we're getting good data, good information, and getting the same resources for those patients that we do for our other trauma patients? These are things that are unique in many instances or many indications for pediatric patients. So how do we as pediatric advocates really try to move the needle on this? So is drowning, still a problem? It's still the leading cause of death for children ages 1 to 4. So yes, it's important. It's something we really should be looking at. So then, it gets down to, should these patients be a trauma activation? What would you gain from that, from it being a trauma activation? Are hangings included as trauma? So we talked about suffocations, co-sleeping, too many blankets, are, patients left in a hot car. So button batteries or any foreign bodies, we struggle with that here. It's like my trauma APPs are the same. They cover ped surgery and they also will cover trauma. They're split on day shift that they may be covering just trauma that day. But if it's a patient with a button battery ingestion, then they're on the ped surgery side. And I'm like, but that's if they, we just had one recently, who needed interventions and had burns and stuff with those button batteries. And it's like, well, then that's considered a trauma patient. So how do you help everybody understand, that what's a trauma patient and what's not a trauma patient? And how do we put them all in the same categories or different categories if needed? So yet above, how many of you, when you think about it, or if you have different programs or within your own program, have any sort of injury prevention initiatives or prevention statements? I know we do. We have for many of these that we actually have injury prevention that actually goes toward talking about many of these types of things. And injury prevention programs are directly linked to trauma programs. So then it's kind of like, is it trauma or is it not a trauma? So dichotomy is kind of the word I came up with. So it's this weird dichotomy that it's like, yes, it's a trauma in some instances, and we want to prevent it, but then it's not a trauma over here because it's not surgical and we can't fix it with surgery. So from the American College of Surgeons and other people involved in the care, do we consider it trauma? It's really difficult, and it's a hard conversation and stuff to have as far as if you want to include these patients or not include them within your trauma registries and what we do for them. So it's also one of those, it's this either or fallacy. It isn't that, do we have to track these patients? Does it mean that they have to be trauma activations? Does it mean that trauma surgeons have to be involved with all of these patients? Or is there some sort of a medium with this? Can it be a trauma activations that's a medical activation so that they get the same resources? They get people down there to help care for those patients, like the radiology techs, like CT, like lab, the people, anesthesia, anyone you might need for a trauma activation, but just maybe not the surgeon. Is there an opportunity to have a different kind of team response that's not necessarily a trauma activation? So it's not necessarily either or. It's there may be a third choice with this. So although on this example, I do like you're either a cat person or a dog person, I think you either are. So I'm not a cat person, I am a dog person. So however, I am not a vegetarian and I do still care about animals. So I like these examples, but I think it just more clearly states that from in the trauma world, it doesn't necessarily have to be black or white, that it is trauma or it's not trauma. There are these gray areas, especially in pediatrics, that we should really look at, and how do we really treat those patients a little bit differently, and making sure that they're getting the same resources, because trauma programs setting up the way that they are really make a difference in all of their PI opportunities and how they really can address different aspects of the actual trauma care or the care of that patient and stuff from beginning to end. So, all right, so does it matter? Why does it matter? So things that I've heard that we actually had in these discussions trying to create a guideline was that, well, the trauma program can't fix everything. So within the program, I disagree. I think we really can. But anyway, but how do we know we can't fix some aspects of it if we don't try? So there's really not great research out there to tell us one way or the other if, any sort of programs that you put into place really would make a difference for drowning patients. So the next one, drowning resuscitation patient care hasn't changed in years. The prevention and teaching everyone CPR is really the key. And it's like, well, that's great, but maybe care hasn't changed or improved because we haven't researched it, because we don't have data to really know if one thing makes a difference or it doesn't make a difference. So it's hard to know if you make a change or implement something or start using a different process, what you could be changing from a care perspective. So I throw that back out to say that that's where, where we really could be looking at this. If everyone supervised their kids near water, the problem would be solved. Well, kids wander off. Supervision is one part of it. My first example that I gave of the first child that I had, unfortunately, in Chicago was a child who was bending over to find something in a mud puddle. and fell in the mud puddle and was top heavy and couldn't get herself out of it. So I don't know that that's necessarily supervision. So there are other aspects of drowning and stuff that we need to keep in mind, although I completely understand that supervision is definitely a part of this. So gates, fences, pool covers, life jackets, all of those things. So I'll have a story as I tell later, but Blake and Kathy Collingsworth are perfect examples. So Blake by trade is a home builder, and they had a pool cover, they had gates, they had an alarm, they had all the bells and whistles on their pool. And unfortunately, one day, this unfortunately happened to them as they were having a family gathering. So sometimes even having that equipment isn't necessarily a guarantee. So there are states who have made laws to make sure that you have those things in place, which again, I think will help. But we don't necessarily know how much they help because, again, we're not really looking at the data or research about it. And then teaching kids to swim would lower the drowning rate. That was my own take on it. But it's there's other parts of it that go with it as well, is what kind of resources does that take to really make sure that kids are, having those resources? Who's going to do it? What age do you start it? Is it with teaching kids about swimming in a swimming pool or swimming in a lake? I have a nephew who was a competitive swimmer, and as that competitive swimmer, he was great in a pool. I mean, he could swim miles upon miles. The first time he was in a lake, he nearly lost his mind because he couldn't see the edge and he couldn't see the bottom. And so he was like, I don't know what to do. And I said, you do, Grant, you just swim. I said, just start any stroke and start swimming. I'm like, you're already treading water. So, and then you have rip tides, which I didn't know a lot about before moving to Florida. I'm from Iowa originally. What do I know about rip tides? But it's another consideration. So how much of the teaching kids to swim do we really do with that? So there are different aspects to consider. So as I said, the leading cause of unintentional death, in 2020, so drowning is still listed first in the 1 to 4 age group. So I think that surprises a lot of people, but it is still a factor and stuff that's out there and something we really need to consider. When you look at those deaths for ages 1 to 4, so drowning is first, then you have birth defects and homicides and cancer and motor vehicle crashes, which are one of some of the other things and stuff that we're looking at from a trauma perspective, but we're still leading with drowning, unfortunately, in that age group. So, and all of this information is coming from the National Drowning Prevention Alliance, who is really trying to do what they can to gather more data and raise awareness as well. So when you look at the proportion of fatal drownings by setting, so you can take all of that information and looking at all the different information and stuff that's listed here. And the part that bothers me the most is 14% of these are unspecified. Unspecified because we didn't have information, unspecified because somebody didn't think to gather that information. But 14% being unspecified is a huge number and is significantly is a significant factor when you're looking at all of the data and stuff that we're presenting. And then when you think about those, and this is also only looking at deaths. So what about those patients who are neurodevastated? So what about those patients who are seen in the ED and sent home? So, and it also has another number here of 14% of these are in bathtubs. I'll talk about that a little bit more in a little while, but was it really a bathtub? So there's been a little bit of a change in sometimes how parents are actually presenting children who may have suffered something else. And then they actually put them in the bathtub and are either washing off evidence or whatever it might be. And so was it really that they drowned in the bathtub or did something else happen with that? So how do we help families following drownings? So what do we talk about with laws to help prevent drownings? So Texas had also passed a law stating that they wanted to assist with ensuring a safe environment around pools and hot tubs. How do we know if it made a difference? It's really hard to say because we don't really have the data to go with it. I love this picture. So this little puppy here, her name's Piper. So she's an Australian Shepherd. I think everyone should have one of her outside of your pool because every time my best friend and I, this is my best friend's backyard and pool, that we would get into the swimming pool, Piper would bark at us if we got too far away from the side and then do a lot of this with the paw trying to draw us closer. So I really think that everyone should have a Piper because I think, that would really help with drowning prevention. I just like Piper, so I wanted to throw her in. And see, I do like dogs. I don't, as a non-vegetarian, I do like animals. So, All right, so further national statistics. So when you look at the non-fatal drowning, so we had some drowning information about fatal drownings, but what if they didn't die? So, the NDPA also pulls this data and stuff, and this is a 4-year time period from 2016 to 2020 that they were looking at those patients who were treated and released. So it was about 59% of the patients that they saw that were coming in for a non-fatal drowning, yet 34% were still admitted, having some respiratory distress, requiring a little bit of oxygen, up to the point of, being intubated, having CPR, and having, further interventions and stuff for that. So that's a pretty significant number of those patients that are still presenting with a non-fatal drowning. But this is the statistics I found really the most interesting. Based on what they could find and the research that they have done on the data that's available, that every child who dies, another 7 or 8 are treated in the emergency department. So keep that in mind as we continue to move forward with some more of this data. So Julie Gilchrist is a doctor that I've worked with on not only this conversation, but also through the Joshua Collingsworth Foundation and the National Drowning Prevention Alliance. So she is actually an emergency room physician at CHOP in Philadelphia, and she also has a huge interest, obviously, in drownings, and has been working with the CDC in trying to figure out how we can do better surveillance and get better data related to drowning prevention. So she gives information that relates to the National Electronic Injury Surveillance System. So some of those slides that I showed you is great. It gives you some data, but what it doesn't do is it doesn't break it down by state or a local level. So how do you know where you're having problems if you can't even break it down by state, let alone breaking it down by city? So if you're having more of a problem in a certain place, then how would you really know that? Based on the data that they have, they're saying that their current data shows that 60% of drownings are occurring in 5 to 6 states. But as somebody who's here to tell you, we have lots of drownings, unfortunately, that happen that people come here on vacation. So it may be happening in Florida, but it's an educational problem or an educational opportunity for every state because people go to travel to those areas where you're seeing more of these drownings. And again, how do we know that that's where the drownings are occurring without having some better data? And we'll get a little bit more into that as we go forward. So drowning prevention really takes a champion in each community, and you really need to work on how you can get better data to really be able to make a difference. So let me get into more specifics, a little bit about data. I've talked about it, but I want to give you more specifics to kind of narrow down why I'm focused on that and why I think that can be an area where we really can make a difference. So the Florida state data, God bless them. I was like, okay, all right, send me what we have on drownings in the state of Florida. And they're like, we're on it. We've got this biospatial thing. It's fantastic. We've got lots and lots of information we can pull from you. I'm like, great. So our epidemiologist for the state was able to pull 620 patients from another database that told me that the EMS records showed that there were 620 patients, 14 or less, over a 2-year time period. Then they had another one on the Florida website that were non-fatal hospitalizations, non-fatal emergency department visits, and injury dashboards, that there were 625. So pretty close that they had, between their two databases that showed that they had 625. Let me keep in mind, this is for 2 years of data that they were recording this. So in 2 years seems potentially low to me. So because when I show you this next slide, that this is the fatal drownings in the state of Florida. So here is 2021 that had 100 deaths from drowning in that same age group. So based on the 7 to 8 patients we'll show to an emergency room for every death, that would show me that it was 700 to 800 patients per year based on having 100 deaths. So 100 patients plus 7 to 8 presenting to emergency departments and stuff would give you 700 to 800 per year. Even if it was 350 of the 625 that we had before, you see where my not believing the data comes in of, yeah, that doesn't make sense. So we seem to be missing some. And how do we make this better? So we're currently in the works here in Florida trying to get better data. And how do we really get better data? in the state of Florida, because we are having a problem with drownings and really trying to get more of the trauma centers and stuff involved. But I won't go too far into that. But the other side of this, back on this slide, was it's nothing specific about where, what type of water, anything about what happened, just that they either went to the emergency department or they died. Okay. Do we really know that it was a drowning? It's really hard to say. The other thing that is very interesting as well is when you look at some of this data, if it's a hurricane, if it's from flooding, or if it's from another type of natural disaster, those don't count in drowning statistics. I don't know why, but those are questions that I have that people don't really have the answers to. They just relate that information to just those natural disasters and not necessarily that it was from drowning. So it's interesting to me. And then Florida has one law currently that was about, public swimming pools and bathing places. Did I mention I'm really not a Floridian? I just want to make that clear. I'm an Iowan, so the Florida laws sometimes are interesting to me. But the rule at first stated that it was about having a pool or a hot tub, and they had all these different supervision and safety rules. However, most of the law was repealed. So the first was put into place in 2009, and in 2016, both of the law was repealed. And the only thing that was left said that owners, managers, lifeguards who are in charge of working at a public swimming pool are responsible for supervision and safety of the pool. I'm like, you mean the definition of what a lifeguard is? I like, okay, thanks for clarifying that in a law. So, but otherwise, there are really no laws, unfortunately, in the state of Florida. So the other part I wanted to point out is in this data that they gave me, anecdotally, so in 2024, I can tell you that in Jacksonville alone, the city that I currently live in, so we heard of in 15 rescues around Memorial Day, we heard of 15 rescues with 2 confirmed deaths one day over Memorial Day weekend. Sadly, we were actually walking along the beach and we're there for the adult death. Anyway, sideline. But that's where it kind of got me more interested in the data that was happening. So then I went through and looked at the weekend before the 4th of July, pulling more data. And Wolfson's alone, my hospital alone, had 5 patients admitted over one weekend. So again, when I look at this data, I'm like, it just doesn't make sense when that's just one hospital and you're giving me all of the data and stuff from across the state, which, by the way, we have 5 level 1 pediatric trauma centers in the state of Florida. So I know that they're seeing more patients than that. All right, we covered this data and kind of covered it from there, although I do like the Alcatraz picture, side note. All right, so then I thought, all right, Oregon, rockin', I'm sure there's better data there. I'm sure they're keeping track of these things. So, I went to Google AI. Why not? When you want to get information, why not go to Google? If you're my husband, that is the answer for everything, that or YouTube. But I went to Google AI and said, all right, Oregon has laws to prevent drowning. What are those laws? Life jacket laws. Great. I'm glad that there's a life jacket law that you must have a U.S. Coast Guard approved lifeguard or life jacket when you're on a boat that's moving. Not on a boat that's not moving, but regardless, if the boat's moving. Life jackets are required class 3 or higher in whitewater rapids. Well, yeah, I would want one there. That's a good place to have one. Boats 16 feet or longer must have life jackets and have a throwable. Anyone operating a personal watercraft must wear a life jacket. Non-swimmers should wear a life jacket. I think that should be a given, but okay, sure. No one under 16 can operate a personal watercraft without being accompanied by someone 18 years or older. I'd love to know how that one is actually being monitored to see that no one under 16 is driving a boat. We currently have that law for anyone driving a golf cart, and that is a joke because I had a 9-year-old just yesterday injured from a golf cart crash. That they're not supposed to be driving golf carts, but it happens all the time. So, and then how many people died from drowning in Oregon? I'm like, I'm sure there's much better statistics. So let me see what I can find out. So they told me in 2024 it was 19, up from 14 in 2023. Then I decided I would look more. And so the first article I found told me that despite many public warnings, Oregon saw multiple accidental drownings this year, that 19 in October had died from drownings. I'm like, well, that's what the last one said. All right. Then I found one that told me that 17 people had died in boating-related drownings between June and September only. So in that 3-month period of time, you had 17 people die. So only 2 died the whole rest of the year. Then it was, they see at least 16 recreational drownings across, or 16 people have drowned while enjoying Oregon's natural waterways since June 1st. And data provided by the sheriff's offices across the state. And then you look at drowning rates per 100,000 in 2023. They looked at older teens and found that, 23 out of 38 may have been prevented if they were actually wearing some sort of personal flotation device. So I felt a little better in that, no offense, Oregon's data is not really any better than Florida's. So sorry. But how do we really take that forward, and what type of things can we learn from it? So what are we trying to prevent? And are we really trying to prevent it? So like I said, earlier last year, when we were reviewing some of the submissions for the Pediatric Trauma Society conference, many of those lectures and educational submissions that people gave for research they've done or projects they were working on had to do with injury prevention projects on suffocations and safe sleep, and a couple that were actually on drowning prevention. So it was fascinating to me that, again, drowning's not considered trauma, but at the Pediatric Trauma Society meeting, we're having lectures on drowning. So I decided I wanted to do my own little survey. So I sent out a survey to ask pediatric trauma leaders, so how many of you do not have a drowning prevention initiative within your trauma program? Again, I've now been at 3 different trauma centers in my nursing career, and every single one of us had an injury prevention program. Again, it's my passion, therefore, of course, I'm going to do it. But I said, how many of you don't have one? So as I asked the question, I had 7 people of 100 who basically, 100 people actually answered, which was great. But 7 of the answered said, we do not have it. Interestingly enough, I would then go to their website, on their injury prevention website, and of those 7, within a couple of clicks, I found 4 of the 7 actually did. But unfortunately, the trauma program, because drownings isn't something they follow, actually are doing injury prevention activities. So it is something that is definitely out there, and most institutions are actually doing. So how effective are the injury prevention efforts? No idea. Safe sleep initiatives, many people are doing safe sleep initiatives. We have a huge one here that we're doing, but is it really making a difference? We don't really know. And there's a lot of single institution studies, which doesn't really give you great data in pediatrics, because it's just not enough patients to really make much of a difference. So what does all this mean? We need better data. And we need to be able to track data. So for me, this wasn't really scientific, but this is kind of this is the information and stuff as I went through and broke it down by different institutions. And so you can see here some of the different hospitals and stuff that I did contact, and some of them are collecting data, some of them aren't. It's kind of all over the place. I had been at Dell Children's in Texas, and Austin was one of my, the trauma center I was at before here, and they actually have a separate state registry again, but the problem was always, okay, we have the data. They didn't know what to do with it. So that's kind of one of those that are collecting data to collect data. But they really needed a plan to figure out what to do with it. So to me, this was just interesting information to really be able to kind of drive home the point of it's incredibly inconsistent what we do, and we need to be more consistent. So this is information from the U.S. National Water Safety Action Plan. So the National Drowning Prevention Alliance is actually working with the U.S. National Water Safety Action Plan to really outline the drowning risks and what we can do for a drowning prevention plan in this country, and it's actually across the world. So other countries are also involved in this action safety plan, and sadly, many different countries were able to come up with their safety action plans long before the United States. It took us longer to figure out how we were going to try to do anything with the water safety plan than some of the other countries. They've actually now come up with one, and we're actually starting to put all of that together. So we'll actually have some more information and stuff as we take this forward, and I'll share a little bit with you about what that is. So, but they outlined that the drowning risk really varies and the burden of drowning is not equal across populations across the country. So, and this may be because of hazards or preventative actions. They also vary greatly across the country. So as you look, it's the leading cause of death. It's the second leading of unintentional injury among children 5 to 14. That is actually a little bit of a misnomer because you still have gunshot wounds, unfortunately, that are running up the hit parade, not as low as 5, but definitely from 12 on up. But death rates vary. They're worse for Black and African American children. So there's more disparities from them as well as for Alaska Natives. But one of the biggest statistics that really stood out for us in the Joshua Collingsworth world is this autism spectrum disorder are 160 times more likely to experience fatal and non-drowning than their neurotypical peers. So actually, I can tell you that Josh Collingsworth, again, I don't get paid anything from them, but they're actually looking at Float for Life classes specifically for autistic children. And many different autistic institutions and organizations across the country are really making drowning prevention kind of a focus of the educations and stuff that they're providing for that age group because of the fact there is such a huge discrepancy in that age group. All right, other drowning risk factors that came out of the water action plan, that drowning patterns may start changing as a result of climate. So more people are seeking water recreation due to it being hotter and global warming. So more intense hurricanes, more intense rainfall, coastal flooding during high storm surges are often occurring with this drownings, although I said sometimes those drownings may not count. But unfortunately, those climate changes are actually causing drowning potentially to be more of a concern. No single government department with a mandated lead for drowning prevention and water safety at the federal level. And there's different than most other countries. It goes on to say that there really isn't a clear lead at the state, county, or community level, creating more challenges for prevention here in the United States. So we're very limited on the data that we actually do have. And then there's really a lack of coordination between different sectors that really exchange data. So how do we make sure that what we have are really commensurate with the magnitude and the economic burden that we're actually seeing from drownings themselves? So the NDPA has listed that they have 5 different layers of protection that are included within this water safety action plan as well. They do list barriers and alarms, the 4-sided fences and gates. Supervision is still listed as having a water watcher, or in my case, a Piper watcher, the dog watcher. He does really well for us from a adult perspective. Water competency, not just proper strokes, but skills to protect themselves in water. So as I talked about my nephew, he freaked out the first time he was ever in a lake. So how do you kind of expose children to different environments so that they actually have skills to be able to deal with those different environments and stuff as well? Life jackets, when used appropriately, are not expected, even when you're not expecting to be in the water. And then emergency protection or preparation, CPR, calling 911, and basic water skills are some of the 5 layers of prevention, which seems to make sense. But sometimes you need to make sure that you have all of those in place, or have at least considered all of them when you're dealing with a water area around your house or your neighborhood. So, all right, more about the water safety action plan. So this just went into effect, or they finalized it in 2023, and it will go till 2032, or really the goals that they've outlined for this. And they've outlined 6 key areas for drowning prevention and activities. I'm not going to go through all of them. We've talked about a lot of them, but I did highlight the number 2 problem that they have is data and public health surveillance, and that they need to better inform and identify risk groups. We have to have data-driven injury prevention initiatives. And how do we do better with that data? So this is really a goal of theirs. So that's part of the reason why I bring this to you guys as well. How do we really tackle this? I talked a little bit about other situations. So, for the majority of this talk, we focus on drowning data, but there are other situations that may not be captured in our data because it may have come in as a drowning. So I don't know about you guys, but we had an infant who presented to the emergency department. CPR was done, had return of spontaneous circulation. We were told the baby was left in the bathtub while mom went to answer the door. EMS report was reviewed. The baby was dry and was not in a bathtub. And come to find out later on that perhaps that's really not the story. And so it later was found to really be more of a case of child abuse and more of a concern of child abuse. We had another child who reportedly came to us, same thing, was from a bathtub incident. And this patient actually was wet, but interestingly enough, no one else was wet. And when they took the child out of the bathtub, didn't get wet. So there were a lot of questions and stuff with it. And unfortunately, doing more of a review, came to find out that this child had skeletal fractures, a head bleed, retinal hemorrhages. So unfortunately, sometimes people are getting smarter, I don't know, dumber, I'm not sure, and trying to either revive a child within a bathtub or running water, or using that as kind of an excuse with the children, also what they're seeing. So. And then you get to suffocating and co-sleeping. What's the workup and stuff for that? And is trauma really ever involved? Because they say that it's co-sleeping. Unfortunately, one of our child abuse pediatricians kind of jokes, but it's one of those, if you ever really wanted to kill your child, suffocation may be the way to go, because it's a really difficult thing to prove that it was done intentionally. So that's another one of those. Are you doing, trauma workups? Are you doing skeletal surveys? Are you looking at those patients to see if there's another injury and stuff that may be out there? And then hangings, is trauma involved? The age of a patient, is that a factor when you look at it? Child and left in hop car, we've kind of talked about. And then button battery ingestions, are you including them as trauma and including them as patients and stuff that you're following within your data? All right, this is all great information, and you can review all of this information. And I don't know about you all, and maybe Jill's involved or someone else from the Randall team. So, but I'm involved in what are called our child death reviews. I get all the fun in my job, but the child death reviews for the county, and basically we can go through and review all of these death cases and make sure that we're sharing information and stuff here. But what unfortunately I'm finding here is there's participants and stuff from many different aspects and stuff of the death reviews, but of those death reviews, we're not even all sharing information and stuff to each other because of HIPAA rules and everything else. So we get into some of these discussions, and sometimes I may have information that law enforcement didn't know about, or DCF has information that, somebody else may not have known about. And so you really get into this situation of how do you make sure that you're at least all talking the same language so that you're actually all sharing the same information to do the best that you can for all of these patients. So I just put that out there from a data perspective, an informational perspective. How do you make sure that we're doing the best that we can and stuff for these patients? So, but the other part of this too is not all patients die. So what about those patients, and what do we really do for that in that situation? So one of the things that we're really working on through the Pediatric Trauma Society and the trauma registry group within that Pediatric Trauma Society is that group called Kids Quip, and they're actually looking at proposing ideas to the Trauma Quality Improvement Program. So the group that we actually download all of our information to for trauma quality to develop more pediatric specific parameters. And really what we've asked for is benchmarking, to look at data benchmarking for data that relates to suffocations, drownings, hangings, and some of the things that we've talked about. So it is something we've started to put into play, and hopefully we'll have more information and we'll be able to provide more information someday soon. So, and then if we were including these patients, we would also ensure that they were also being screened for acute stress, like our trauma patients are receiving. So, how do we really help patients that may have suffered this if they live through it, or how do we really help their families get through this as well? So this next video is a video of the Joshua Collingsworth Foundation leaders, Jake, Blake, and Kathy. And I just wanted to share it with you to share a little bit more about their story and a little bit more about the next subject I just want to touch on briefly.
Both of my children are adopted. We were on a 2-year waiting period when we got Joshua. It was 2 weeks before Christmas, and we were called and said, there's a baby. We need to go. You need to pick him up. He smiled constantly, and everybody loved him.
It was a beautiful spring, June day, and lots of people hanging out at the house and hanging out at the pool. And some of the people left to go get barbecue stuff, and other family members were getting ready to come over. And through that transition of that process, there was a time when the pool was totally empty and nobody was there. I was up in my front office, and I remember hearing Kathy say, "Have you seen Josh?" And when you hear those words about a child, your heart drops, you swallow hard. But then I started moving out of my office immediately, and then I heard her scream. And I don't know why, but I just started bolting to go downstairs to get to the backyard, and she was almost running me over. And my brother-in-law was right there too. And so all three of us got out there, and she had seen him in the backyard floating in the pool. I walked up to the pediatric ICU, and Kathy was laying in bed next to Joshua with all the tubes and everything. And the doctor walked out and met me at the door, and I said, "How's he doing, doctor?" And he said, "There's no hope."
It was a hard decision to take him off all the life support because I didn't want to let him go.
We kept searching, how do we get something good to come from this, even at that moment, trying to just grasp for something good to happen out of what you get. It's like getting hit upside the head with a 2x4 is what it's like. And kind of knew that if you're going to sit around the dining room table and talk about water safety, it's not very practical. It's probably going to go right over their head. So I also knew that children love characters. They love purple dinosaurs. They love all sorts of different characters. So we started looking around and said, what character would be appropriate that would engage a child that we could introduce this message to? And when we saw online otters holding hands and floating, and you go to the children's zoos, and all the children's face, they're just up against the glass and giggling and laughing and watching the otters play, it made perfect sense. Once we decided to create the book, what was amazing is if you look at the pictures in there and even the cover, Josh the otter has Joshua's eyes. We hear so many people say the story's fabulous, but the pictures are fabulous as well. And that was the whole point, is how do we engage children, not scare them, but get them to start automatically thinking the way that they do. And if they go into a swim school and they're not scared, they go in and say, hey, I want to be like Josh the otter. And they're excited to go in and learn. And that's what we need to be driving home with kids. And it's just a question of how many kids we can reach with it. How do we start the conversation? Drowning prevention is such a vast, diverse problem. And there's so many different aspects of it that we as society need to do to make a difference. Whether it's learn to swim or fencing or alarms, all the different things that we need to do, but we need to start the conversation.
I just know that being a mother that lost a child from a drowning, that there's a lot of stigmatism that comes with having lost a child from an accident. Drowning is 100% preventable. And if we can create the education and the awareness out there, we will continue to save lives in many countries, many states and local communities throughout the world. That's our goal, is to stop drowning from happening to another family. Both of
So I share that story with you, not only that I think it's a powerful message just talking about how drowning has affected one family, but it's also looking at how, with, traumatically injured children from a drowning, it's very similar to any trauma. So in the trauma world, we talk about nothing is, an accident, so that everything is preventable. So how does drowning not fall into that same category? Also, I think one of the things that I really heard differently when I listened to Blake and Kathy speak this time was about the emotional parts of this and the emotional safety parts of this, as far as I was in that room, when the doctor came in and I didn't hear him say that there is no hope, but that's what Blake took from it. So how do you make sure that the messages and stuff that we're giving those families and we're working with those families is something that can be something that will help to keep them, emotionally safe? You heard Kathy talking about, that there's a stigma and stuff that's attached with this. There's a stigma that's attached with many traumatic injuries and stuff that kids of ours, may have. And how do we help those families in dealing with those types of of situations, there are trauma survivor networks and stuff that are out there. And how do we really now include also drowning patients in those same trauma survivor networks so that families feel like they have support and they have someone out there who understands what they've been through. And it's not just, wow, you weren't watching your kid and he drowned. So I think it's really an interesting an aspect and stuff of this. And I had an opportunity when I was president for the Pediatric Trauma Society to attend an emotional safety conference put on by the Association of Child Life Professionals that really talked about keeping our kids and our families emotionally safe, not just physically safe. We have all these, serious safety events and safety measures and stuff that we put into place for keeping our kids safe while they're here, but how do we keep them emotionally safe? So there are 4 pillars that come with it, and it's screening and assessments and interventions and the environment itself. And then there's communication, education, and education and training. So I encourage you to do more learning and stuff about how to keep kids emotionally safe and engage with your child life specialists and stuff as well as we continue to move forth and really want to keep looking at gathering more data, having more data available, really incorporating some of these drowning and other injuries and stuff that are happening to our kids so that we're actually having better data and being able to do something to help to prevent them, that we're actually also looking at the emotional side of this from all aspects. Not this is motor vehicle crashes or gunshot wounds or whatever might be happening. How do we make sure that we're keeping our kids emotionally safe as they go through this process as well? So all right. That being said, here's a list of my references. So, and then I just wanted to share, this is a little bit of my why. Excuse me. So the 5 on top here, these yahoos up here are my grandkids. So, I've moved on. So the 4 below are my nieces and nephews that were all big swimmers and actually continue to swim even as adults. And I'm very proud of that fact. But that's really the why of why I continue to do what I do and why I really like what I do. So we're close, but I'm happy to take any questions. So Jill, or if you guys want to let me know kind of questions and stuff that are there, and I'll flip to this last slide so that people can get their credits and kind of take it from there.
Thank you so much, Lisa. Oh my goodness. Does anybody have any questions for her today? Let me just take a look here. You guys go ahead and put them in the chat. I'll take a look and see if we've got any questions. It's just very, very touching and very moving. Let's see here. So Melissa Butler commented, I don't understand why this isn't a topic of discussion from birth on, starting in the hospital and continuing with education, with pediatrician visits. We do a lot of safe sleep prevention, teaching why not add drowning prevention.
You get right on that, Melissa. I completely agree with you. So again, in Joshua Collingsworth and, some pediatricians, they, are really starting to do more about, getting kids swimming lessons and stuff, but they start at the age of 2. But when you look at Float for Life programs, if you've ever seen babies who've fallen into a pool, or, any kid who may have fallen into even a, body of water or a bathtub, how do we teach them to flip over and be able to, float and stuff in those situations as well? So is 2 early enough?
Right. Yeah. April says, great presentation. Thank you. Caroline says, thank you so much. Yelena says, thank you. She's one of our PICU nurses. Craig from our trauma center, thank you for a great presentation. Sharon says, thank you. Debbie says, thanks so much. I mean, I think one of the things that I found disturbing, scary was that autism spectrum disorder that they see 160 times. They're more affected. That number is very, very scary to me. Yeah. Do you have any?
I can tell you actually in the last 6 months, so going through and looking at some of our data. So again, I have to do it on the side because it's not in my registry yet. I have to get through some reviews this year, and then after that I'll start changing my data. But in the last 6 months, even looking at this, we've had 4 different kids at retention ponds, and all 4 of them were autistic that unfortunately drowned in retention ponds. So it's very interesting that is one of those aspects, and so and why specifically that age group and why that disease process, I'm not sure, but it's definitely more to look at. One of the other things I didn't share in here, but that was really good news for me that I've heard within the last 6 months also is the CDC has actually now at least got a one FTE person who's looking at drowning and stuff for the United States. Okay, it's better than what they had before. Other people were doing it as bits and pieces of their job, but they actually have a person who's now focused on that at the CDC. So hopefully more information and stuff can come from that, and we can really take things forward. So, but I give credit to the Kids Quip group and stuff with the Pediatric Trauma Society and those registrars. They're really, man, they're fighting the good fight. To see what we can do from a PEDS trauma center standpoint and stuff is really being able to gather the data, because without data, we don't really know what we're doing or not doing, or if it's helping or not helping. So,
yeah. Jennifer says, thank you for your hard work and dedication to this topic. Mandy says, thank you. Kat says, thank you. I don't know if Amber Croker's on. I saw her on earlier. She's with our Child Safety and Prevention at Randall Children's. I don't see her. I don't see her on here. But anyways, they did a swim with Santa in November, December. And Jill was there. Yes. So I know that we're kind of, have efforts in the help as well. Pam says, thank you. Melissa says, thank you for great information in this presentation. Is it Washington Watch Me Grow program has a mailer at 9 months regarding drowning. Though certainly agree it's never too early for this education. Yes. Thank you, Melissa.
Right. And I know Washington State is one of the other states that actually does keep drowning data. But in talking with, Dr. Tony Escobar, who's actually in Tacoma, isn't he? I think he's in Tacoma. Now I have to think. I've known Tony for years. I should know. But he's the first one to tell you that they have data. They don't really know what to do with it. So that's really the problem. Is it's like now we've got some people who are collecting the data. So we really need to put forth, different aspects and different research studies and stuff to see, what's actually making a difference and how can we actually track that. So.
And Brennan says, Brennan with Emergency Services says, thank you for all the great information. Yeah.
You are very welcome. So I don't have my contact information on here. But Christy or Jill, if anybody has any questions or wants to reach out, I'm more than happy to provide any information or, any contacts and stuff that you need. So, and Blake and Kathy say, thank you so much for, allowing me to, or actually, I thank them for allowing me to show this video. And they're just like, wherever you'd like to show it, we're good. They just want to, do whatever we can to really raise the awareness for drowning prevention. So they're amazing people. And I've worked with other parents, unfortunately, who've been through the same thing, who are doing great projects across this country as well. So, but how do we fight the good fight? So.
Yeah. Well, thank you. Thank you so much today for coming and speaking to us. Thank you for your passion. We really appreciate you and we appreciate your time and let us know how we can join your efforts. Right, Jill?
Thank
Absolutely.
you, Lisa, so very much. Thank you.
Yeah. Oh, you're very welcome. Anytime, y'all. Have a good, happy Thanksgiving. Happy Thanksgiving. Happy Valentine's Day. See, the cold has caused problems up here.
Jordan says, thanks, Lisa, Jill, and Christy. What a fantastic presentation. Thank you, Jordan. All right, you guys. Well, we will let you go. But yes, thank you again, Lisa. Thank you, Jill, for you guys for being here. Have a great rest of your afternoon. We'll be in touch, Lisa.
Great. Thanks, you guys. Take care.
Thanks, you guys. All right,
Bye-bye.
Take care.